Bueno, buenas tardes a todos. Gracias por sumarse a la charla del día de hoy del Comité de Cardiología del Ejercicio, que es muerte súbita en el atleta, la visión del cardiólogo, la visión del patólogo. Realmente un tema que siempre convoca y siempre nos deja con bastantes dudas y sobre cómo proceder en relación sobre todo a esto y a la evaluación predeportiva. Y hoy tenemos a dos exponentes realmente de primer nivel. Es un orgullo contar con ellos. El primero de ellos es Gherardo Finocchiaro. Gherardo Finocchiaro es cardiólogo consultante del Hospital St. George's de Londres y también del St. Guy's and Thomas de King's. Él está especializado, por supuesto, en cardiología del deporte, tiene numerosos papers de cardiología del deporte y sobre todo de muerte súbita, y también tiene mucha experiencia en lo que es imágenes cardiovasculares. Va a hablar primero Gherardo, vamos a hacer después una ronda de preguntas, el que quiera a través del chat puede realizarlas y se las pasamos a él. Lo hacen en inglés o lo hacen en castellano, es lo mismo. Y luego va a hablar Mary Sheppard, que la presentaremos entonces oportunamente. Gherardo, thank you for joining us. Thank you for your time. It's really a pleasure for us to count on you. So whenever you want, we listen.
Thank you very much, Esteban. I took my slide. Thank you very much. Okay, so thank you very much for the invitation. It's really a pleasure to be with you this afternoon and to discuss about epidemiology and causes of sudden death in athletes. I work at Guy's and St. Thomas's and St. George's University in London, in the group of Professor Sharma, Professor Sheppard, and this was a topic that to me is particularly interesting, and I spent, I will say, probably the last 5 to 10 years studying this particular topic, and I will try to communicate this interest in yourselves as well. I will try to move on with the next slide. Okay, so these are the learning objectives. So in the next 40 minutes or so, we will review the epidemiology of sudden death in sport. We'll discuss the variability in incidence of sudden death and identify the high-risk populations. We will discuss the etiologies implicating sudden death in athletes. I will show you some of the data from St. George's University Sudden Death Database. We will discuss screening methods. So first of all, let's discuss about the epidemiology of sudden death in athletes. What is the magnitude of the problem? So when we are asked, well, what is the incidence of sudden death in athletes? Well, I would say that probably the easiest answer we can give is that sudden death in athletes is fortunately rare. But if we are asked to give some numbers about the incidence of sudden death in athletes, we see from these slides that nicely summarize this issue, that the numbers are very, very different. There is an extreme variability according to different studies. Is there any high-risk population? Well, I will say that probably this study, which is an American study, a national registry of NCAA college athletes, so that means age 19 to 23, showed that sudden death in male basketball players was 1 in 5,200 athletes per year. This is the highest described. Okay, 1 in 5,200 athletes every year. But if we look at the other end of the spectrum, we see that there are numbers that are extremely different. So let's have a look at this slide. This is again an American study. It's not a national registry, but it's just the state of Minnesota. Year 1993 to 2012, so 20 years. The age is slightly different from the study that I just showed you. So the athletes are slightly younger, 15 to 18 years old. In 20 years, these authors witnessed only 4 sudden deaths. So the incidence was 0.24 per 100,000 athletes per year. So that means roughly 1 in 300,000. So we've seen before 1 in 5,000. This study is 1 in 300,000. So a huge difference. Something that we have really to keep in mind is that, of course, we all learn about sudden death in athletes from the media, from the newspapers. But we have to remember that sudden death doesn't affect only the high professional athletes. Clearly, professional athletes are the ones that make it to the first page of the newspapers because, of course, they're very famous. And clearly, there is some attention from the media because it seems almost counterintuitive, almost paradoxical that an athlete, especially an athlete that is performing very, very highly, can drop down dead on the football pitch or on the basketball pitch. We have to remember that, however, sudden death occur in everyone, also in non-professional athletes. Okay, and we have to remember that sudden death doesn't affect necessarily only young athletes, but also young individuals in general. Okay. Another important topic to discuss is the etiology of sudden death in athletes. And I will show you that in the last 20, 30 years, there's been a quite significant change in opinion about the etiology of sudden death in athletes. So I think that probably many of you have seen this slide before. This is a slide that is deriving mainly from 2 important studies from Dr. Maron's group in the United States. These studies showed, they were published in JAMA in 1996 and in Circulation 2009, showed that hypertrophic cardiomyopathy is the most common cause of sudden death in young athletes. For young, in those studies, young was considered less than 39 years old. So HCM, 35% of the cases. So these studies, very powerful studies, basically created the opinion that the most common cause of sudden death in athletes is hypertrophic cardiomyopathy. However, other studies showed very different results. And this is an example. This is a study from northern Italy, from Professor Corrado's group in Padova. This study was, again, on young athletes, and the authors showed that the most common cause of sudden death in these athletes was arrhythmogenic right ventricular cardiomyopathy. Okay? I have to say that this study benefited from a centralized system of a cardiac pathology lab localized in Padua with experience in these particular conditions, and where basically the cases were referred from the region, from the Veneto region in northern Italy. The Maron study, instead, were based on death certificates mainly, so not necessarily on autopsy reports that were not done in all cases. And also, something that is important to underscore is that while in this study, in the Padova study, as I said, basically the authors relied on information based on a cardiac pathologist, so on someone who is specialized in assessing hearts of individuals who die suddenly. The Maron study was based on autopsies which were performed by general pathologists, not necessarily by a cardiopathologist. This is another American study published on JACC. It is a study on military personnel. A 10 years period, sudden death events were analyzed. It was a retrospective study. We see that here we have another entity that is coming out. Less than 35 years of age, we have a 41% of sudden unexplained death. What does it mean? It means basically a sudden death where the pathologist assessed the heart at the postmortem and cannot find any structural abnormality. So that is a normal heart at the postmortem. It's called sudden unexplained death, or also called sudden arrhythmic death syndrome. Similar results for this more recent study from the United States again, published on Circulation. This was on college athletes, age 19 to 23, national registry led by the Seattle group. And we see that here, sudden unexplained death, or SUD, so normal heart at the postmortem, was the most common finding at the postmortem, so 25% of the cases. Instead, we see that just 8% of the cases were diagnosed with hypertrophic cardiomyopathy at the postmortem. So very different results from the pie chart that I showed you at the beginning. These are data from our lab at St. George's University. This is a study on individuals who were diagnosed with hypertrophic cardiomyopathy at the postmortem after they die suddenly. And we see something quite relevant. We see that, first of all, not all of these individuals died during exercise, but instead, there was a majority of patients with hypertrophic cardiomyopathy who died at rest or even during sleep. A minority, just 19%, died during exercise. Something that I would say is almost counterintuitive is to think about hypertrophic cardiomyopathy as a major cause of sudden death in athletes. Why? Because generally speaking, patients with a hypertrophic cardiomyopathy, especially if they have features of severe forms with significant left ventricular hypertrophy, for example, cannot perform in terms of exercise. This is a study that we did at Stanford University, and measuring particularly the peak VO2 at cardiopulmonary test. You see that most of patients with hypertrophic cardiomyopathy, 40% of the cases, tend to have a reduction, significant reduction, less than 80% of the predicted peak VO2. So if we think that athletes generally perform with a peak VO2 that is 110, 120% of the predicted, this is saying something. So I will say there are also other studies that in some way confirmed this change, this paradigm shift, that basically is telling us that hypertrophic cardiomyopathy doesn't equate sudden death in athletes. But generally speaking, sudden death in athletes can be caused by a series of conditions, such as, for example, anomaly coronary arteries, sudden unexplained death or sudden arrhythmic death syndrome, so normal heart at the postmortem, myocardial fibrosis, arrhythmogenic right ventricular cardiomyopathy. And probably hypertrophic cardiomyopathy is not the most common cause of sudden death. I just want to briefly discuss with you our cardiac risk in the young and St. George's experience in London. So with this study, which was published in JACC a few years ago, we tried to investigate the causes and circumstances of sudden death in a large cohort of athletes, reported by an expert cardiopathologist, Professor Mary Sheppard. We tried to report on the contribution of a relatively novel entity, such as, for example, idiopathic fibrosis or idiopathic left ventricular hypertrophy. We will talk about that. So just to explain you briefly the way it works, probably Mary Sheppard will go through all this in more detail in her talk. So basically, when there is a sudden unexpected cardiac death in the United Kingdom, the case almost all the time goes to a cardiopathologist. It goes to a local pathologist, which is a general pathologist, which performs a general post-mortem examination. Then the general pathologist can refer to our center in London free of charge, so can refer the heart or the slides. And our center is an international recognized cardiopathology center in the United Kingdom. We have the facility to do analysis of the heart, of course, macroscopic analysis, histopathological analysis, even molecular autopsy, so looking at the genes that can potentially be associated with a cause of sudden death. So between the span of 20 years, between 1994 and 2014, more than 3,500 cases of sudden death were collected. And out of these 3,684, 357 were athletes. Some of them were competitive athletes. Some were recreational athletes. And these are the type of sports. So we have a prevalence of runners. Some of them were marathon or half marathon runners, football player, cyclist, and other sports. What were the causes of sudden death? So first of all, I would like to say that 90% of these individuals were males. The causes of sudden death. So in 42% of the cases, we found a normal heart and the postmortem in the presence of a normal toxicology. So that means that this was a sudden arrhythmic death syndrome. We see that other causes, like for example hypertrophic cardiomyopathy, which were more rare, so 6%. ARVC was 13%, and then other pathologies, like for example coronary abnormalities, were present in 5% of the cases. If we look at different age subgroups, we see that younger athletes, there were very unfortunate athletes that died less than 18 years old. There was an absolute predominance, I would say, of SADs. And then instead, if we go at ages that were 18 to 35 or more than 35, then we see that there is more a predominance of other conditions. This study is very much in keeping with the results of this other important study that was published in New England Journal of Medicine just a few months after our study. This was a national study in Australia and New Zealand of all sudden death cases in young individuals, less than 35 years old. And we see that these authors showed that unexplained sudden cardiac death, so that means again SADs, was present in 40% of the cases. Going back to our study, we see that there is an association between age and etiology. And this is summarized very nicely also by these slides. We have to remember that, of course, individuals that are over the age of 35, even more over the age of 50, the prevalence of coronary artery disease as a cause of sudden death is definitely more significant. Something also that I would like to underscore is the fact that dying suddenly and being an athlete doesn't mean necessarily dying on the pitch. We may have some individuals that die suddenly at rest or even during sleep. We try to look at the etiology of sudden death in association with causes and other factors. And we see that there is a very strong association between ARVC, arrhythmogenic right ventricular cardiomyopathy, and sudden death during exercise. Something that is quite important to remember is that, as I showed you before, there is a prevalence of male sex in cohorts of sudden death in athletes, in historical cohort, as we see here. It was also in our study, so 90% of the cases were males, just 27 cases were females. There were some differences in terms of causes of sudden death, and we see that females were more commonly affected by, more commonly the postmortem finding was a normal heart. we see that cardiomyopathies were more frequent in males. If we look more closely, we see this clinical entity, which is not very well defined, to be honest, which is called idiopathic left ventricular hypertrophy, which basically means a heavy heart with some increased wall thickness without significant myocardial disarray present only in males. Why sudden death is more common in male athletes? Well, there are several hypotheses, but no certain facts. There is the possibility that there are some genetic factors or some hormonal factors, or the fact that maybe males tend to exercise more to their exhaustion, or maybe also myocardial fibrosis, which has been shown to be present mainly in male athletes. Something that I would like to underscore is that sudden death in non-athletes also was characterized by a prevalence of male gender. In summary, so if we want to summarize what I just said, so there is an extreme variability in the epidemiology of sudden death in athletes. Possibly young male basketball players are at higher risk. There is an extreme variability in the etiology of sudden death in athletes. We describe this paradigm shift. There is a relatively high prevalence of AIVC in Italy. AIVC is associated with exercise-induced sudden death. Recent years, SAD seems to be an important cause of sudden death in the young and in athletes. And sudden death seems to be more prevalent in females. We are left with many questions, and I will try to discuss some of them with you. One of the most poignant questions is sudden cardiac death in athletes epidemiologically relevant? Sudden death in athletes is rare, but it usually affects young individuals with a significant loss of years of life each death. So this is something that is important to remember. Is sudden cardiac death in athletes more epidemiologically relevant than in non-athletes? Athletes with cardiac disease appear to be at higher risk of sudden death than non-athletes. However, we have to remember that non-athletes are numerically more than athletes. The relative risk of sudden death in athletes. This is a study from Gherardo from some years ago, who showed that there is a relative risk of 2.5 in athletes with respect to non-athletes. But if we go on the other side of the Atlantic, in the United States, according to Maron, there seems to be a higher risk of sudden death in non-athletes with respect to athletes. What are the hypotheses behind the triggers of sudden cardiac death in athletes? Well, the fact that basically there are a series of physiological changes, including dehydration, electrolyte imbalance, adrenergic surges, acid-base disturbance, which are very well tolerated by an individual who doesn't have a cardiomyopathy or a cardiac disease. But all these physiological changes become difficult to tolerate and a potential trigger for ventricular tachyarrhythmias in individuals with a vulnerable substrate. What can we do as a society to prevent sudden cardiac death in athletes? Well, screening is a possible, very controversial way to identify as a risk. We have to remember that athletes who die suddenly are often asymptomatic. To screen or not to screen is clearly a significant dilemma. There are significant issues that are related to this question. Issues about sensitivity, specificity, ethics, cost effectiveness. One of the most poignant questions is, does cardiac screening save lives? Because this is what we really want to achieve as a society. So who should we screen? How? This is an important study, again, from the patólogo group, and it's basically the only robust evidence that the screening saved lives. So we see on the left of the panel sudden death before before a national policy for cardiac screening was implemented in Italy at the beginning of the 1980s, a policy including the use of the ECG. And we see that at that time, in the late 70s, beginning of the 80s, the incidence of sudden death in athletes was around 3.54 cases per 100,000. And we see that during the years, there is a drop in the cases of sudden death in athletes. And this is the explanation for that, is the fact that the screening policy had been implemented and, of course, improved during the years. And this was the main reason why screening works. However, we have other studies which show something different. So, for example, this is an Israeli study where we have cases of sudden death which were reported according to media reports. And we see that there is not really a change in the incidence of sudden death. There is clearly some criticism to cardiac screening in athletes. This recent review appeared on the BMJ. There are different models to screen athletes. This is the Italian model, which has been basically embraced by the European Society of Cardiology, which basically relies on family history, personal history, physical examination, and the crucial part is the 12-lead ECG. If the ECG is positive, then we can use further examinations, like, for example, echocardiography, 24-hour Holter, MRI, to rule out a cardiac condition. The American model is slightly different. It relies on the 14 points from the AHA, which are basically based on the personal history, family history, basic examination. ECG is not considered. The UK model, the UK doesn't have a national policy for screening of athletes, but professional athletes are screened through the respective international organization protocols. Charities offer screening. There is no compulsory screening for non-professional athletes. The Cardiac Risk in the Young, which is a charity that I've been working with for many years, which is a very is a charity that offers cardiac screening in athletes and non-athletes in the United Kingdom, basically embrace the ESC/Italian system. So the ECG is crucial. If there are some changes, then further test and referral is suggested. I think that an important point to underscore is that symptoms do not discriminate between individuals who may harbor a cardiac condition that may be potentially dangerous, potentially fatal, and individuals who instead should be given the all clear. And this is, I'm just putting in comparison in this slide a study from Harshad Dutia from our group at St. George's, showing how when we do cardiac screening, there are often symptoms reported. Young individuals report chest pains, or palpitations, or sometimes loss of consciousness or presyncope, which are not clearly relevant after scrutiny. But on the other side of the spectrum, individuals who die suddenly don't have symptoms before. So 86% of the cases in this cohort did not report any symptoms. So the etiology of sudden death, we have touched before. We've said that there's clearly some changes in the understanding of what is causing sudden death. There are clearly a lot of question marks about causes, especially about novel entities, such as, for example, idiopathic LVH or idiopathic fibrosis. That means basically finding some hypertrophied heart or heavy heart, or some myocardial scar, which we cannot put in a basket, in a nomenclature basket, to classify in some way well-defined cardiac condition. So these are findings, but can we really call this is a disease, or is this just a trait of the disease? So there are clearly cases like that, and these are not rare. It's important to do family screening in these cases, because we often find that there are some conditions that are diagnosed in family members. This is a study from Michael Papadakis from some years ago, showing that family screening in the individuals with findings of uncertain significance at the postmortem leads to diagnosis of channelopathies and cardiomyopathies. Clearly, something that is very important for me to underscore, but I'm sure that Mary Sheppard will stress this point even further, is that a specialist cardiac investigation should be the first crucial part of our workup. Because if we don't rely on our post-mortem findings, on our post-mortem diagnosis, how can we really offer answers in the surviving members? We have to start from clear points from a specialized cardiopathologist. This is a study that we did recently at St. George's on family screening of individuals who die suddenly with idiopathic LVH. We asked ourselves the question, is this idiopathic LVH, so this heavy heart and increased wall thickness in individuals who die suddenly, is this hypertrophic cardiomyopathy? I just remind you that these cases, there was no myocardial disarray, okay, which is in some way considered the hallmark of hypertrophic cardiomyopathy. So what did we find? We found that there was no hypertrophic cardiomyopathy in the family members of these individuals, and instead there were channelopathies diagnosed, like Brugada syndrome or long QT syndrome. It's very, very important to remember that sudden death is something tragic in an athlete or in a non-athlete. It should not be the end of our thinking process. Instead, should be the start of our thinking process, because we always have to remember that there are surviving family members with a lot of questions. The first question is, why? Why my brother, my son died suddenly, and he was apparently healthy? And therefore, we have to really provide a reliable answer. We have to rely on our cardiopathologist. So, as I said, it is the starting process of family screening. It's a process which is often complex, challenging. It's not an easy journey. It's often an emotional journey. Also for us physicians who have to assess these families. But it's important to be precise, to be accurate, to give answers, because often there are also questions from the families. Well, I mean, my child died suddenly. What about his little brother? Is he at risk? We don't want to lose, of course, another child. We need to do everything to prevent. It's important to identify normal heart, as I said, sudden arrhythmia death syndrome, because family screening may provide some diagnosis which can be missed opportunities. So, for example, in this case, we have a case of Brugada syndrome. And I think I will stop here with my take-home messages. So, there is an extreme variability in the epidemiology of sudden death in athletes. There is a paradigm shift in the etiology of sudden death in athletes. HCM is not the most common cause, but sudden death in athletes is caused by very different causes. Sudden death is most common in males and in male athletes. Screening of apparently healthy athletes has a role in prevention if a 12-lead ECG is used. Family screening after sudden death in a young athlete may detect family members at risk. So we have to remember that when there is a sudden death, we have to start working on family members. Thank you very much for your attention.
Well, thank you, Gherardo. Really an outstanding presentation, very useful also for the daily practice. And as you showed, and many papers are doing, there's a shift towards another cause, or more commonly cause, instead of HCM as the main cause of sudden cardiac death. So if you want, as you need to eat, I've got two questions for you. One is if the lack of development of innervation of the left ventricle could have a role in as a trigger in sudden cardiac death. Do you have some information about that?
The lack of innervation. Well, I to be honest, I don't think so. To best of my knowledge, I never encountered studies on this specific topic. I think that generally speaking, I think probably the attendee who asked the question was referring to sudden arrhythmia death syndrome. I think that these cases are generally caused by channelopathies, or this is what we assume, based on the diagnosis in family members. So I don't think that innervation probably has a great role in this, but I think that instead channelopathies are the causes, and in some way there has been some evidences about supporting this, also from molecular autopsy.
Okay. Another one, it's related to COVID. It's possible that the COVID may have some sequelae, cardiac sequelae in a high percentage of athletes, as two papers showed. So, in your opinion, which are the risk markers for sudden cardiac death in people affected by COVID? Certainly in athletes, but also non-athletes or recreational.
Yeah, no, of course. Yeah, I mean, I think there is a growing evidence about COVID. I don't think we can have definite answer on this. I think clearly we have to consider the fact that COVID may cause patterns of myocardial injury and myocarditis and inflammation of the heart related to COVID itself. So I think that this may be a cause of sudden death in athletes and non-athletes. I'm not aware of cases of COVID where in some way the sudden death was the first presentation of COVID-19 infection. I think that possibly sudden death in these cases may occur in a clinical framework where probably the infection and also the respiratory manifestation prevail. I'm not aware of situations where the myocarditis and therefore the possible propensity of developing some ventricular arrhythmias related to the inflammation are the first presentation of COVID-19. But yeah, I think definitely athletes may be at risk because there could be some more tendency to meet more people, and I think this may help in spreading the virus.
So, do you think we should MRI more frequently athletes up to now, or from now on?
To MRI athletes with COVID-19 or in general?
Yes. No, COVID-19.
Well, I think that we have to consider what are the benefits and the risk of MRI in this specific context. I think the MRI may, in this context, clarify a diagnosis of a myocarditis as the cause of, for example, an increase in troponin, which would otherwise be defined as a myocardial injury. However, there could be some some issues related to the feasibility of cardiac MRI in these individuals. First of all, because we know that cardiac MRI is not so widespread like echocardiography, so there are some hospitals that don't have access to cardiac MRI, but also because in the specific context of COVID-19, there could be some issues related to transporting, for example, the patient to the cardiac MRI suite and then putting at risk more personnel and losing a lot of time to clean the area. This are things that should be put in the equation when we think about doing or not doing a cardiac MRI in an athlete who has possible features of COVID-19 related myocarditis.
Okay, this is another one. I will try to translate it. It says that there's some experience in minimal invasive autopsy with images as an alternative to autopsy did by cardiac pathologists, for example. What's the importance of this? Or the relevance? It's physical.
Yeah. So I think that the question relates to the use of, for example, cardiac MRI in individuals who die suddenly, so before going to the post-mortem, so basically doing a non-invasive autopsy. I think this is really a growing, exciting field and would definitely provide some information. However, I think that the role of the cardiopathologist and of specifically of histology, I don't see it as possibly replaced by the use of a non-invasive cardiac MRI, at least at the moment. And I'm sure that Mary Sheppard can elaborate on this, but there are often cases where, for example, fibrofatty infiltration or myocardial fibrosis is very subtle and comes out after a very accurate analysis, both from a macroscopic and a microscopic standpoint of the myocardium. I don't think that the cardiac MRI is able to capture these features at the detail that autopsy is able to provide, at least at the moment. I see Mary Sheppard is online, so maybe she can elaborate on this.
Mary, your microphone.
Yes, I got it off. Can you hear me?
Yes.
Just to reiterate what Gherardo, by the way, thank you for the invitation to say that no, at this present moment, that MRI or even limited biopsy is not useful. It's in an experimental stage. Yes, in the future, but at the moment, MRI or any other technique of CT scanning will not provide specific answers in the cardiomyopathies or even confirm that a heart is absolutely normal. But in the future, yes.
You know that we don't have cardiac pathologists here, so it might be difficult. That's why we raised this question. Yeah. Okay. Well, there's no more questions for you, Gherardo. As you need to leave, we really thank you to joining us.
Thank you very much for the invitation.
Very useful. Very nice to see you again.
Thank you.
Okay. Hope to see you in the international conference. So, thank you very much, Gherardo. Mary?
Yes. Do I bring my presentation or will you bring it up?
Okay. I will introduce you. Okay. Bueno, continuamos entonces ahora con Mary Sheppard. Mary Sheppard es anatomopatóloga especialista en cardiología y sobre todo especialista en muerte súbita cardíaca, realmente una de las personas creo que a nivel mundial con más experiencia en la autopsia de atletas en general, pero sobre todo de muerte súbita, sobre todo en jóvenes. que trabaja en el hospital Disertantes y bueno, tiene numerosas publicaciones también que lo ratifican. Bueno, Mary, do you want me to share my screen or you share
Yes,
yours?
you share. No, I will share my screen. So will I? Thank you very much, Esteban, and I am delighted to be invited to participate in this webcam investigation of sudden death in athletes, which Gherardo already spoke on. My role here is to tell you about pathology and the importance of pathology when investigating a sudden death in athletes. I have no declarations of interest, and I wish to tell you that the autopsy is still essential when you have a tragic sudden death in an athlete. And here is a survey from Europe showing the variation in autopsy rates, that even in Russia we have no information and the autopsy rate is very low in many European countries. And we have one among the highest in the United Kingdom and in Austria. But in other countries there are no figures on autopsy rates, emphasizing the variability of autopsy investigation. How I became involved in sudden cardiac death was with the British Heart Foundation in the 1990s, where we established, not unsurprisingly, as you all know, that ischemic heart disease is the most common cause of sudden death in the general population, particularly the older. But this was the first study to emphasize SADS, sudden adult death or sudden arrhythmic death. 7% of our cases, the heart was absolutely normal. 6% were due to cardiomyopathies. And so this study was the first to emphasize a normal heart with the introduction of channelopathies. As a result of this work, and already mentioned by Gherardo, the charity called CRY, Cardiac Risk in the Young, funded a pathology service because they understood how important it was to get a diagnosis for the family. We opened in 2009 and we are at St. George's Hospital, where we receive hearts from throughout the whole United Kingdom, as you can see on the map. And we look at the heart and study it and take samples for histology. In addition, we give a report to the pathologist and to the medical investigator. And we set up a database, which is very important for the research that Gherardo has undertaken with Sanjay Sharma and with Elijah Bayer and Michael Papadakis. We get the heart to look at, and in addition, we also get now a piece of spleen freshly fixed so that genetic studies can be carried out, as Gherardo has emphasized the importance of channelopathies and cardiomyopathies which are inherited within families. So samples are sent with the heart for genetic testing. This is our most recent study emphasizing on an annual basis the amount of hearts we receive from throughout the United Kingdom. And in addition, in blue, you will highlight the number of spleens. We are now getting genetic material in over half our autopsy cases. Other pathologists are sending this material. So we are doing molecular autopsy. With every case, we're undergoing genetic investigation. This is very important. This is the sampling that we do when we look at a heart. We analyze it, measure it, weigh it, see if it's hypertrophy, dilated, scarred, and then sample. This is essential. Every case should have sampling. We take histologies, blocks, and we enter the results into this database. We have the history, the age, the sex, the body weight, previous family history, ECGs, imaging. We do all measurements, photography, histology, and the cause of death. This is all entered, and we have over 6,000 cases now. And here you will see the number of cases we have got, of which 44% had sudden adult death. The heart's normal. The majority of sudden death, this is obviously a younger population, or SADS. Then next come, because we still have ischemic heart disease in 15%, 9% what Gherardo called idiopathic left ventricular hypertrophy. We have Hcm making up just only 3.9%. In other words, Hcm is not the most common cause of sudden death. It is similar in athletes. Arrhythmogenic cardiomyopathy make up 3% and dilated 2.9%. All these have genetic possibilities, so the family should be screened. The role of the pathologist in all cases is to get rid of non-cardiac causes such as subarachnoid hemorrhage, respiratory pathology and drugs, important in athletes as well. And then we go on to the cardiac causes. And we have to decide as pathologists whether it's a morphologically normal heart or whether there's a cardiac abnormality, a cardiomyopathy, to be identified. We must remember non-cardiac deaths in sport. Trauma, obviously, heat stroke, exercise-associated hyponatremia, drugs, asthma, and subarachnoid hemorrhage. The pathologist, with the clinician, obviously will eliminate these causes, and toxicology. But remember, trauma can occur, and here's from Thomas, a study of children dying in young competitive athletes, and the majority are less than 21, and it's usually impact head and neck injuries, and football was the most predominant. But you may also know that a blow or trauma to the chest can cause sudden death. This is known as commotio cordis. If it causes damage to the heart, it's called contusio cordis. And we had published on this in Medicine, Science and the Law in 2014, or 18, sorry. And it shows it's a non-penetrating blow by a football or by a baseball that causes a cardiac rhythm disturbance in a normal heart, which results in cardiac arrest and sudden death in a young athlete, particularly very young teenage athletes, and again, young. Here from American Marins, young baseball players. Direct over the precordium, a direct impact, blow to the chest by a football, but you can also be during assault or also and trauma directly by striking of a golf club or a road traffic accident. The heart is normal in contusio cordis. Here you can see an absolutely normal heart, and it's at the upward on the T in the QRS complex that is the window of vulnerability that causes ventricular fibrillation in a perfectly normal heart. Contusio was there's bruising, particularly with road traffic accidents. There's bruising over the chest, and there's bruising on the heart itself, causing an onset of ventricular fibrillation, contusio cordis. So a lethal blow to the chest, an underdiagnosed cause, we think, of sudden death in United Kingdom sports, particularly with football, cricket and rugby. We published this with Susanna Cooper in 2019. Again, like with all sport, males predominate. 17 of the cases were, in males. The mean age was young, 19 years of age. And what were the sports? Football, cricket and rugby. But assault and other conditions like a blow into the chest by a horse kick and being hit in the chest by a swing in the playground. But remember that in sport, the circumstances must be important to rule out commotio cordis. Young males at most risk, transmission over the precordium. Obviously, the predominance of male is linked to the fact that males participate in more high-impact sports. And due to a lack of a national registry, we think these are underestimated of the true number of cases in the United Kingdom, and I'm sure worldwide as well. Deaths in the London Marathon from 1981 to 2017, there was only 714 deaths. 5 were ischemic heart disease and 3 cardiomyopathies. In other words, 57% were cardiac, 43% non-cardiac. So ischemic heart disease, because it's a big, broad population with middle-aged to older runners. Heat stroke, exercise-related hyponatremia, drugs and subarachnoid were also causes. So here are the London Marathon cardiac deaths showing HCM, hypertrophic cardiomyopathy, and ischemic heart disease. Now remember, ischemic heart disease with thrombosis in a coronary artery and infarction is pretty easy to identify. Here is chronic narrowing of a coronary artery by atheroma, scarring in the ventricle. Remember, very young people can get atheroma. Here's an 11-year-old girl who collapsed on a school run. And this is her aorta, which shows raised atheromatous plaques, looking like the aorta of an 80-year-old. And these are her coronary arteries, completely occluded by lipid-rich atheroma. When I phoned the mother about this, mother told me the family had a history of familial hypercholesterolemia. Her daughter had been asymptomatic and had never been screened for this. She's the youngest case I've had of precocious atheroma. Now, already mentioned by Gherardo, sudden deaths in young athletes. We eliminate ischemic heart disease, we eliminate contusio cordis, we eliminate all these coronary arteries. Anomalous coronary arteries must be considered, and Gherardo has published with me on this, it's a leading cause in young athletes, and also premature atheroma, as we already mentioned. Remember, aortic dissection can also occur in athletes, very rare. Anomalous coronary arteries, where two arteries arise in the one sinus and go between the two great vessels. And even with investigations, they can have a normal ECG and echo when people are investigated for chest pain. They should have a CT angiogram, really, to look for the origin of the coronary arteries. That is very important to eliminate anomalous origin of the coronary arteries. And we must remember that not all blocked arteries are due to atheroma. Here's a boy of 13 who is sudden death at school playing football. He has a blocked coronary artery, but it's not atheroma. It is intimal and medial fibromuscular dysplasia. This is where there is myofibroblastic proliferation in the intima and media blocking the vessel. We do not know what causes it, but it is a disease caused in families, but it is not genetically established at this moment in time, but important to eliminate as a cause of death with histology. In addition, when you have thrombosis in a coronary artery, be careful to look, and this is why the pathologist needs to look very carefully. This is the coronary artery, as you can see there highlighted, but the thrombus is outside the media in the adventitia. And this is an example of spontaneous coronary artery dissection. And here again, you need histology to show the dissection with an inflammatory response. It is not familial. It can also be seen in young pregnant females, and it may be drug-related, particularly cocaine in males. So as we say, toxicology is always important. Autopsies can be inconclusive who die in marathons. This is where you need a very good autopsy with detailed examination of the heart and toxicology. So as Gherardo said, sudden death in athletes, you must look for anomalous coronary arteries. You look for hypertrophic cardiomyopathy with scarring. You look for the septal hypertrophy. You look for the fatty infiltration here in arrhythmogenic cardiomyopathy. You look for the dilated thin wall ventricle in dilated cardiomyopathy. And you come and look at the normal heart, do histology to make sure the heart is normal when you consider sudden arrhythmic death, and investigate the family for channelopathies. This combined with electrolyte imbalance, dehydration, as he already mentioned, in catecholamine release, etc., as precipitating the sudden death during sporting events. Here is hypertrophic cardiomyopathy, thick wall ventricle, and on your right is the histology showing the disorganized myocytes, the dilated cardiomyopathy here, and here you see the myocytes in yellow surrounded by bands of pale pink collagen. Dilated cardiomyopathy, both are inherited and family must be screened. Here is arrhythmogenic cardiomyopathy, fat replacing the right ventricle, but also the left ventricle. As we have established that the circumstances of death in all our database, 11% are sport related. Of our 6,000 cases, 11%, right? Exercise related. And this is Sophia de Norhoja's work. And she showed with our earlier study of 118 deaths, young athletes, males predominating, amateur athletes, 85%, running, football and rugby were the predominant sports. And the results, as Gherardo may have already highlighted, cardiomyopathies predominate, the normal heart channelopathies, coronary artery pathology, and other cardiac pathologies we must always consider, like myocarditis and floppy mitral valve. Here highlighting that atherosclerosis or atheroma occurs in the older athletes, whereas anomalous coronary arteries occur in the younger athletes. Idiopathic left ventricular hypertrophy, Gherardo referred to. It is where you have a heavy heart over 500 grams. And when we look down the microscope, this is big, chunky, meaty heart, very small lumen, very thick muscle with or without fibrosis, and the patient does not have hypertension. And when we do histology, as I see here, the myocytes are parallel and evenly distributed, and there is no myocyte disarray. This is what we call idiopathic left ventricular. And as Gherardo said, it is not related on family follow-up to hypertrophic cardiomyopathy. Is exercise the cause of this hypertrophy and fibrosis is a big challenge for the cardiologist, and I think it's only with follow-up cardiologically will we establish the etiology of this entity, which is now becoming much more important as a cause of death, much more common in our experience than hypertrophic cardiomyopathy. And here's an example with extensive pale fibrosis throughout the left ventricle, highlighted by histology, which shows myocardium in yellow and the collagen and scarring in red. And you often have slight floppy mitral valve changes, subtle changes, which Gherardo already mentioned. So you cannot say this is the cause of death because it's quite subtle. You need to do histology on the myocardium to establish a cardiomyopathy. We have specific criteria already published in Gherardo's paper in Sport on how we pathologically define these individual entities of hypertrophic cardiomyopathy, idiopathic left ventricular hypertrophy, idiopathic left ventricular fibrosis, and arrhythmogenic cardiomyopathy, as well as myocarditis. We followed these quite specifically in all cases to get a very strong pathological phenotype at autopsy. So when it comes to the normal heart, we can be quite confident we have not missed a subtle cardiomyopathy or myocarditis. And as I'm sure Gherardo may have said, in athletes, SADS predominates in younger age group up to 40, whereas as people get older, cardiomyopathies predominates. In other words, I think cardiomyopathies express their phenotype much older in athletes, whereas SADS expresses the phenotype in sudden death in younger athletes. Here's the work that Gherardo did, which I already mentioned. So hypertrophic cardiomyopathy and arrhythmogenic are two important entities causing sudden death in athletes. And I will send you examples. Here's an example of one. Total fatty replacement of the right ventricle, scarring in the subendocardium and scarring on the right side of the septum with transmural fatty replacement. Here's an example where the right ventricle is not involved, but the septum and the left ventricle is, where the arrows are, is pale areas of scarring and fatty infiltration on the epicardial surface of the left ventricle. And here's another case where you've marked fatty hypertrophy and infiltration of the right ventricle and also scarring and fat in the left ventricle. Here is histology confirming collagen, the fat, and the fibrosis highlighted with a red stain here. That is essential to do in all cases. Here is Chris Miles, who did a comprehensive study of 232 cases of arrhythmogenic cardiomyopathy, showing it's a biventricular disease, and 45% of the deaths occurred during sport. So it's emerging, in my experience, as an extremely important cause of sudden death in athletes. This was published in Circulation last year. Already, I'm sure Gherardo may briefly mention about sudden death in patients with hypertrophic cardiomyopathy. What the point made is that 78% were diagnosed at autopsy. In other words, the athletes during life did not know they had this condition. So it's important for pathologists to make the diagnosis. In other words, the family is then followed up. Male predominant, fibrosis, and even some coronary artery disease, although it was non-significant. So very important to make this diagnosis because the autopsy is vital to make it for the family. Triggers for the sudden death, as already Gherardo meet, when you have myocyte disarray or the electrolyte imbalance, dehydration, etc. So I finally wish to thank and acknowledge the team at St. George's, which Esteban you were very familiar and worked with, Sanjay Sharma, Elijah Byrne, Michael Papadakis, as well as Gherardo. So thanking them, and also my own team, because we do this work, Craig totally funds that helps the family of both athletes and non-athletes. Thank you very much.
Okay, thank you, Mary. Thank you, really. I know you are on vacation in Portugal, so you just, as a gift, lend us a bit of your time in your holidays. Outstanding, as always. I would like to, there's a question here, if there's an association with left ventricular dilatation with ACM.
Is there a link of ventricular
dilatation, dilated cardiomyopathy and HCM.
and
Yes.
Oh, as you know, hypertrophic cardiomyopathy can go on to dilated. It can dilate in older patients. But I don't really find in athletes, I find hypertrophic cardiomyopathy is either a thick ventricle or a normal ventricle. The ventricle can look macroscopically normal and the heart rate can be normal. It's histology with myocyte disarray that really gives you the diagnosis of hypertrophic cardiomyopathy. And if it looks dilated with histology, there'll still be myocyte disarray to give you the diagnosis of hypertrophic cardiomyopathy, even if it's dilated.
Okay. The mitral valve prolapse, it's a very frequent condition diagnosed during the life. So when do we have to worry when we diagnose a mitral valve prolapse in relation to sudden cardiac death?
Very good question, Esteban. Mitral valve is very common in athletes, and the big question is they can die suddenly with this. But I have found that mitral valve is a very rare cause of sudden death in athletes. And you know who it occurs in? The sudden death occurs in young women with mild mitral valve prolapse. And they have a mild disease, but they have scarring in the posterobasal wall of the left ventricle and also the posteromedial papillary muscle. So I think in anybody who has a history of mitral valve prolapse with arrhythmias, they should have an MRI to look for this scarring because they're at risk of sudden death during exercise. But I think it's females, interestingly, in contrast to males. And we have not yet got, I think they have a history of arrhythmias during exercise with mitral valve prolapse. That's are the ones at more risk.
Okay. The last one, you talked when you came to Argentina, a question about atherosclerosis in veteran athletes. Do you have any further information regarding the risk of these people going to kind of master athletes with great training amount?
Well, as you know, atherosclerosis, Sanjay has done some work on this, haven't they, with angiography showing that elite and veteran athletes have calcification in their coronary arteries. But it's actually not linked to atheroma. It is just calcification, and the lumen of the artery is not compromised. So as we know, calcification is used as a link to atheroma. But in athletes, it does not seem to be linked. Why they get calcification in the media of their coronaries, we do not know. But on follow-up, to my knowledge, there hasn't been an increased incidence of myocardial infarction or cardiac failure in those patients with the calcification.
Okay.
So it's a fascinating area that needs investigation by cardiologists.
Yes. So there's another one, and I think we will stop here. It says, if idiopathic fibrosis or LVH could be a finding and the true cause of death in sudden cardiac death, as sudden unexpected death syndrome as a subset. If we make the diagnosis of idiopathic left ventricular hypertrophy or of idiopathic fibrosis, what we advise is the family should be screened. We don't yet know the genetic background, but we advise that the family, and I think now we're getting more and more information as to, is it a familial disease? Is it related to exercise? Is it acquired or genetic? We simply don't know yet. But at the moment, we advise screening of the family. If I make that diagnosis, I will advise them be screened by the cardiologist. Okay, but to diagnose a sudden cardiac death, you should have a normal heart.
I tell them I obviously cannot diagnose it. I just say that it is normal. Okay. And I say that the family should be screened for the possibility of channelopathies.
Okay.
But as you know, sometimes, I'm sure you're aware, Esteban, that even with a heart on family follow-up, some patients with a normal heart at autopsy have a cardiomyopathy on follow-up.
Yes, of course. Yes.
The person who dies does not manifest the cardiomyopathy. The heart's normal, but the family have a cardiomyopathy. So they may develop the arrhythmia before they develop the cardiomyopathy. So this is a fascinating, challenging area as well, because as you know, some of them, besides having channelopathy genes, have cardiomyopathy genes. And yet when we look at the heart, it's normal. This is an area that is further needs exploring.
Okay. Okay, well, there's no more questions. We don't want to... So, Mary, thank you very much.
Thank you for the invitation.
Can you hear me? Yes, okay. So thank you very much. We really thank your presentation, to joining us in your vacation, in your holidays. So go on and enjoy. And okay, thank you.
And thank you, and enjoy the rest of your meeting. Bye-bye.
Thank you very much. Bye-bye. Bueno, muchas gracias a todos. Damos por terminada la sesión. Adiós.